Hello and welcome to the Parkinson's Foundation's webinar on Breaking the Silence on Mental Wellness for Veterans with Parkinson's. I'm Krista Ellis, your host for today's webinar, and helping me behind the scenes are my colleagues Danielle Agpalo and Laura Cameron. Today's program brings awareness to the symptoms that are often unspoken among veterans with Parkinson's. We will address the real impact of loneliness and isolation, offer strategies for managing post-traumatic stress disorder, and provide guidance on overcoming fears associated with symptoms. And we'll also share resources and support options designed to relieve isolation and nurture meaningful connections. Today's webinar and the entire Veterans webinar series is presented with support from the Don and Lorraine Freeberg Foundation. We want to take this moment to thank the Freeberg Foundation for helping to make these programs possible. The mission of the foundation is to make lives better for people with Parkinson's, whether you are living with Parkinson's, caring for someone with Parkinson's, or working to end the disease. We are here to support you. To achieve our mission, we pursue three goals: improve care for everyone with Parkinson's, advance research toward a cure, and empower and educate our global Parkinson's community. Today's program is a great example of one of the things we are doing to help us meet these goals. The Parkinson's Foundation hosts weekly education and wellness programs through our PD Health at Home virtual programming. Join us for Mindfulness Mondays, Wellness Wednesdays, and Fitness Fridays. Most of the PD Health at Home programs are recorded and posted on the Parkinson's Foundation's YouTube channel. You can scan the QR code on the screen to connect to that YouTube channel, or find out more and register to attend our live PD Health at Home programs at parkinson.org/PD Health. Part of the foundation's commitment is to reach every person living with PD. A critical way we do that is through our partnerships. With more than 110,000 veterans living with Parkinson's disease, the foundation is proud to have established a formal partnership with the Veterans Administration. This partnership has the overarching goal to improve the quality of life for veterans living with Parkinson's disease and their care partners through greater access to education, resources, and support. I'd like to invite you to visit our webpage and explore the resources offered by the Parkinson's Foundation that can support your navigation of living well with Parkinson's as a veteran. And that website is parkinson.org/veterans. And I'm happy to kick things off by welcoming Dr. Ellen Bradley. Dr. Bradley is an assistant professor of psychiatry at UCSF Weill Institute for Neurosciences at the University of California, San Francisco. Dr. Bradley, thank you for sharing your time and knowledge with us today.
Of course. Thank you so much for that, Krista. Really kind introduction. And thank you so much for inviting me to be here. I really appreciate the chance to talk with you all today. So like Krista said, I'm a medical doctor trained in psychiatry at UCSF, and I split my time doing research and then working with patients who have PD in our clinic. And it's great to be able to be here and speak about this topic about mental wellness, connections, especially for veterans who I work with quite a bit. Because as a psychiatrist who's working in movement disorders, I think about this a lot. How can we help to promote wellness? How can we help folks strengthen connections when they are living with PD? So today, what we'd like to do is we'll have two parts. First, I want to talk a bit with you about what the problem is, how PD can lead to isolation, can create this disconnection, especially for the veterans and the additional challenges that can come with being a veteran. And then we'll have a brief break. And then when we come back, I'd like to jump into what we can do about this problem. So, what are potential solutions? And then I'd love to hear questions from this group, especially folks who are actually walking this walk, living with PD and trying to navigate these challenges. All right, before we get started, I do not have anything to disclose. Okay, so why are we even so worried about this problem of isolation and disconnection from other people? Why is it such a big deal? Why are we, having a whole session about it today with you all? And the bottom line is, and this is true not just in PD, but actually for all of us, we know that isolation, the feeling of social disconnection, that those things are really bad for our health. Feeling more isolated and lonely actually has these real negative consequences. And in PD in particular, we know that it can make people's symptoms worse. It's also associated with faster cognitive decline, and it can put people at risk for developing even more medical problems on top of PD, problems with their cardiovascular system, with their mobility, just to name a couple. And, we don't know exactly how the problem of isolation negatively affects health, but, there are some theories that possibly it's because it can really disrupt our sleep. It can also disrupt our body's natural stress response. And it also may even impact the way our immune systems function. So feeling isolated is really not good for anyone. Okay. So a challenge for people with living with PD is that, the symptoms of PD can do a lot to really feed isolation. I'm sure that folks here are already familiar with this analogy that PD can often be kind of like an iceberg. There's this big chunk above the water that, is kind of what we all think of most readily when we think of PD, the motor symptoms, the slow movements, the tremor, the rigidity. But then there's this bigger part that is kind of hidden under the water that is harder to see, and a lot of people don't even know about. Things like sleep problems, fatigue, pain, cognitive issues, autonomic problems like changes in blood pressure, hallucinations, and then anxiety and depression. And this is because, as you all know, the degenerative process in PD, it impacts a lot of circuitry in the brain, not just the circuitry that is responsible for our movements. And more, we think of PD as really not only a movement disorder, but really a complex neuropsychiatric disorder because of all of these things. So I think we can all agree that, each of these different symptoms of PD can contribute to folks feeling isolated and disconnected, right? Like physical limitations that from the motor symptoms, like having trouble speaking loudly and clearly, being distracted because your phone is beeping, reminding you that it's time to take levodopa, a tremor that's interfering with eating when you're trying to have a meal with your friends, feeling self-conscious about shuffling when you walk. All of these things, right, can really mean that, it's not like surprising to us that a lot of people with Parkinson's can become isolated. Sometimes we feel that if we limit our contact with the outside world, then we'll have less kind of to worry about, less explaining to do. And that feels a lot easier in the moment. The ability to kind of just avoid situations that can make you feel different from other people. Even though, all of these issues that people experience with PD can contribute to isolation, so really they'd all be relevant to, what we're talking about today. But I want to focus in a bit more on these mood changes, on the depression and the anxiety, because these can be often the hardest to see. They're like the deepest underwater. And sometimes they're the last thing we doctors and other providers even ask you all about. But that really shouldn't be the case because these are so common in PD. We think that it's probably well over half of people with PD that are dealing with anxiety or depression. Many are dealing with both. And it's really, really impactful. These mood changes are associated with having a faster cognitive decline, a faster physical decline, and they're actually even stronger predictors of quality of life with PD than how severe your motor symptoms are. Even though they're so important, they're so often underrecognized and therefore undertreated, like I said. So that's why I really want to talk about them today. Why do we think that mood is so important? Well, mood can color our view of everything on this list, of the whole experience of having PD. And I think that's how depression and anxiety can end up keeping people from living well with PD, can contribute to that isolation, that lack of social connection. I was working with a patient a couple of years ago with PD, and he was telling me that he was, really bummed that he wasn't going to church anymore. Church had been a huge part of his life, and he had a social community there. He really loved going regularly, but he stopped going. And he told me a few times that he'd stopped going because of his tremor. And he said, it's the tremor. That's the reason why I can't go to church. And I started to ask him more about this. I was like, well, what do you mean? How exactly does the tremor interfere with you going to church? And then he said to me, well, I think about, what other people around me in the pews would think, that they might get freaked out. They might not know what was going on. They might think something was wrong with me. And they would stare at me, and then I would feel self-conscious, and then, it wouldn't be enjoyable at all. So, we talked about this for a while, and what we really came to was it wasn't exactly that tremor was standing in the way of him going to church and enjoying himself. It was really anxiety about that whole experience. And, he was really able to kind of focus on tackling the anxiety in order to get back to doing something that he liked to do. So just an example of how kind of mood really does influence our whole view of our experience. Okay. So we used to think of mood changes in PD as, I think, purely, maybe we'd say like a psychological reaction to having this very difficult disease. And there's a lot of kind of appeal to that view because, of course, it's very intuitive. It's very hard to have PD. It is stressful and challenging. And so it makes sense that people would feel anxious and depressed. But we know now from a lot of research that that is probably not the whole story of these mood changes. We think that the mood changes may actually be part of PD itself. There are, several changes that are happening in PD that also are related to our mood. And I'll just quickly go over some of them here. So one thing is imbalanced monoamines. Monoamines, of course, are these chemical compounds that act as neurotransmitters in our brains. And the monoamine that we think about most in PD is dopamine. But PD doesn't just impact dopamine, it also is impacting other monoamines like serotonin and norepinephrine. All of these are really important for maintaining a healthy mood. Another thing is what we call decreased tropic support. So tropic factors are these proteins that are super important for stimulating the growth and survival of our cells. So they're really important for brain health. And we know that these are reduced in PD. And we also know that they're very important for mood as well. Another thing is dysregulation in what we call the hypothalamic pituitary adrenal axis. This is this hormonal communication system that's responsible for regulating our body's response to stress. This is also struggling more in PD, and we know that regulating a stress response in a healthy way is important for our mood. Inflammation in the brain. We also think that this is something that plays a role in depression and anxiety, and we know that it is a huge part of what's going on under the hood in PD. And then lastly, this idea of oxidative stress. That's the imbalance between these unstable molecules in our bodies called free radicals that can harm cells, and protective antioxidants. And when we have that imbalance, that oxidative stress, that leads to our mitochondria, pictured here. Mitochondria are these little organelles that live in our cells and are kind of they're the energy powerhouses of our cells, of our cells. And this oxidative stress makes the mitochondria less effective at meeting our energy needs. This is something that's happening in PD, and we also think it could be related to mood changes. We don't know yet if one of these mechanisms or all of these mechanisms might be a contributor to mood changes, but these things might explain why it's so common that we see the mood changes that we do in PD. And we're hoping that research in the next several years can kind of shed more light on this issue. Okay, so really important for our focus today, something that we have learned from research in the past few years is that dealing with PTSD or having a traumatic brain injury, a TBI, actually raises people's risk of developing Parkinson's years later. There's research that has looked at hundreds of thousands of veteran records to understand this. We don't exactly know how this link might work, but it's possible that these war-related illnesses like PTSD and TBI could kick off changes in the body and the brain that kind of drive the development of Parkinson's disease later. And it's possible that this is related to our system for managing stress in the body, as well as levels of inflammation in both the body and the brain. But regardless of kind of what the mechanism underlying this relationship is, this research tells us that the veterans who have experienced PTSD and TBI are more likely to develop PD. And so we really want to think about their particular challenges. As you may know, there's quite a bit of overlap between PTSD and TBI symptoms. PTSD, of course, the things that we think of as being quite common are hyperarousal or feeling on edge all the time, having re-experiencing of traumatic events, either at nightmares or flashbacks, and social avoidance, kind of steering clear of situations that might feel triggering. With TBI, people may often have headaches, dizziness or balance problems, can also have impulsive, kind of uncharacteristic impulsive behavior. And then symptoms that are found in both PTSD and TBI that I want to highlight are, again, depression and anxiety, so these mood changes, irritability, difficulty with concentration, and insomnia, as well as fatigue. So this disrupted sleep often leads to insomnia and fatigue. And I highlight this because, many veterans, if they are dealing with PTSD or TBI or both, may already be dealing with some or all of these symptoms, often for years before they are even diagnosed with PD. And if we look at this list, I think we can all imagine how a lot of these problems here can contribute to making people feel more isolated. So I think that the reality is that many veterans have been dealing with the consequences of these symptoms, and one of them is isolation, for a long time, even before they're diagnosed. And we don't always do a good job of recognizing this, right? And sometimes people, humans can be so good at kind of adapting to symptoms over time, adapting their lives around the symptoms, that we kind of don't even catch that these things were going on before someone was diagnosed with PD. I worked with a veteran a while back who had PTSD for many, many decades. And but he told me that actually the PTSD wasn't really a problem for him anymore. And I was like, wow, that's great, not bothering him. And then we got to talking about stuff he liked to do. And he told me that his favorite thing in the world was watching baseball games. And I asked him what was the last game he went to. And he told me, oh, I haven't been to a baseball game in over 30 years. He says, I can't go to a baseball game. It would be too triggering. I would have PTSD. So it's interesting, in his mind, he was like, PTSD isn't an issue for me, but he had, been taking these steps so long to avoid the symptoms that, he'd ended up kind of distancing himself from things that he really, really loved, like going to baseball games. Okay. Just some quick, points here before we go into taking a break. I think the things that I really want to highlight today are that first of all, that mood changes are so common in PD, and they are so important because they're linked to lower quality of life, and we often don't recognize them, so they go untreated for too long. And I think this is really important because we know that these mood changes, one of the ways that they negatively impact people's quality of life is that they contribute to isolation. They reduce social connection. We also know that these mood changes are not something that folks with PD can just kind of shake off. We think that they may actually be part of PD itself. They could be related to changes that are happening in the brain. And so we really want to treat them, just like we treat other symptoms of PD, trying our best to improve them because we think that that is going to help people live better with PD. And we'll talk more about that after we take a break. And then lastly, symptoms of both PTSD and TBI, which are very common in veterans, can make it harder to manage PD. Because if you've been living with PTSD or TBI already, you may already be feeling isolated. You may already have kind of stepped back from social connections even before receiving a PD diagnosis. And then PD can come with its own mood changes, and that can make it more challenging for folks to feel resilient and to be proactive about living well with PD, about taking good care of themselves. Okay, I'm going to go ahead and, if it's okay, we'll go to the break now. Take 5 minutes, and then when we come back, we'll talk about what we can do about this problem, and then I'm hoping to be able to leave some additional time for questions at the end.
Thank you, Dr. Bradley. And now we're going to offer a quick 5-minute stretch and movement break led by Sydney Boggs from Beaufort Memorial's Delayed Disease Program. Feel free to step away from your computer or stay and participate. And we'll see you back here for the second session with Dr. Bradley in about 5 minutes.
So today, what I'm going to do is I'm just going to show you a glimpse of what we do in Delay the Disease. I'm going to start by getting you guys warmed up. We're going to do a few balance exercises, and then after that, we'll just do a few stretches, all right? So to start, what we're going to do, you can either do these in a chair or you can do them standing, but what we're going to do is we're going to do some high knees. So if you're in a chair, you can kind of scoot to the edge of your chair and just lift your knees up, or if you are standing up, you can get beside your chair, hold on to it if you need to, and you're going to lift those legs up as high as you can, keeping your core nice and tight. So we're going to do this about 20 times, and I think I'm about on 6, so we're going to go 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. Good. Next, what we're going to do is you're going to have a seat, and we're going to do sitting jumping jacks. So just like you did in gym class, what you're going to do is start by your side. When your arms go out, your feet go out. All right, same here. You're going to do about 15 of these. 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, and 15. Good. All right. Again, you can either do these next exercises sitting or standing. we're gonna get our smaller joints warmed up. So we're gonna start with our wrists. All right, so we're gonna hold our wrists out just like this, and we're gonna turn them in a circle. Just try to keep your wrists, not your whole arms. Gonna do a few rotations one way, and then we'll switch to opposite directions and do them the other way. Same thing, about 10 or 12 on each side. All right, good. And shake those arms out a little bit. Next, we're gonna do big arm circles. So you're gonna go big arm circles forward. Try to get a full range of motion, making big circles with your arms. And we're gonna go backwards, doing the same thing. 3, 2, 1, and relax. All right, if you're already seated, great. If you're not, go ahead and have a seat because we're gonna warm up the ankles next. So what you're gonna do is you're gonna put one foot out, and just like we did with the wrist, we're gonna go with the ankles. So we're gonna start by going to the right, doing about 10 each side, 4, 5, 6, 7, 8, 9, 10. And then we'll switch to the left foot, same thing, going to the right. Try to make a O with your toe. 4, 5, 6, 7, 8, 9, 10. Good. All right, from here, you're gonna extend your leg. We're gonna work from the hip. All right, so we're gonna try to make big circles with our legs, trying to get as much as we can. Going to the right, 4, 5, 6, 7, 8, 9, and 10. Good. Switching legs, same thing. 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. Good. All right. So for the next exercises, we're going to be focusing on balance. So what I'm going to have you guys do, you are going to stand to the right of your chair. And if you need help with your balance, it's fine. You can just hold on to the chair, or if you don't, that's fine too. But the goal here is we're going to go into a staggered stance. So you're going to start with your right foot forward, your left foot behind. Have your feet about 6 to 8 inches apart. Okay, I don't know if you can see, but I am they're diagonal from each other. My left foot's behind me. So what you're going to start doing is you're going to come forward on your toes and then rock back on your heels. And we're going to do this about 10 times, coming all the way up and then all the way back. That's 4, 5, 6, 7, 8, 9, and one more. That's 10. Good. So now we're going to do the same thing, but we're going to lead with our left. All right, so our left foot's in front, our right foot's behind us, same thing, 6 to 8 inches apart, staggered stance. Coming up on our toes and back on our heels for 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. Good. All right, shake those legs out a little bit. All right, guys, that is all I have for y'all today. I hope you enjoyed it, and thank you guys for having me.
Thank you, Sydney, for guiding us through movement, just to get our bones and joints and muscles moving a little around a little bit before moving into our second session with Dr. Bradley. Dr. Bradley, thank you again for joining us today, and I look forward to learning more from you as we continue this webinar.
Thanks, Krista. All right. Okay, thanks, Krista. Can you hear me now?
Yep, I can hear you
Okay,
and
great.
see you.
All right, great. Thanks, and thanks for that great break. That was really nice. We should do that in all of our long meetings and presentations. Okay, so what are we going to do? What can veterans with PD do to improve their mood? So I want to talk about this because we just talked a few minutes ago about the problem of isolation and the fact that depression and anxiety are really big contributors to that problem. That I would say is, the bad news that those problems are quite common in PD, and that many veterans were already dealing with those problems even before they had PD. The good news, however, is that mood can change. We have a lot of great ways to help people improve mood, to tackle depression and anxiety. So I really encourage people to think about, which strategies we talk about today, speak to them, and consider, trying some of them out, because even though we don't have, there we go. We don't have a cure for PD right now, but that doesn't mean it isn't hugely important for folks to be doing everything they can to, I think of it as kind of putting money in the bank. I think that, it's easy for us to, we don't always think of, tackling depression and anxiety this way, but often it's easier to think about like the example of physical therapy, right? I think we all know physical therapy is so, so important in PT. Why? Because even though it's not curing PD, it is doing a ton to help people build physical strength and build resilience. So it doesn't mean the PD goes away, but of course it can mean that living with PD will be a lot better. People can fall less. They can be less likely to get injured if they do fall. Same with our strategies to improve mental health and reduce isolation. I think of them the same way. It's like if you can kind of put this money in the bank as early as possible when you have PD, that's fantastic to kind of really build your resilience to the challenges of living with the illness. People who are able to do this, to kind of invest in getting more connected socially, tend to, with PD, have better access to information about kind of best practices, things that work for other people in their community. So that can really help people kind of dial in their own treatment. They also tend to get much more emotional support, which we know is really hugely helpful as people are dealing with different challenges. That the disease is always changing. It's always throwing a new curveball, and really great to have that support from others. Folks who get more socially connected also tend to be able to manage stress, change, and loss of function in kind of healthier ways, and to bounce back faster when they deal with a physical setback. And also, being more connected often leads people to be able to kind of seek out opportunities to help others. They tend to think more about what it's like in the shoes of others. And we know that taking the opportunity to help other people can often really offer physical and mental health benefits to ourselves. Like it feels good to help other people, to kind of be useful in our community. So all of these are kind of potential benefits to think about when we're thinking about why we want to, reduce isolation as much as possible. So I wanted to just talk about kind of a few of the key strategies that we use to support mood and PD. And this first one is what we call behavioral activation. And this is a technique that is really grounded in the idea that there is a vicious cycle of kind of inactivity, withdrawal, and isolation that contributes to mood problems. Here we're showing depression, but the same is true with anxiety. And if we can break that cycle by gradually helping people increase their level of activity, people tend to feel better about themselves and have a brighter outlook on life. It tends to create this kind of virtuous cycle, and then people tend to want to do more of the things that are important to them. This all, of course, I think sounds good and looks really intuitive. We all want to go from a vicious cycle to a virtuous one, but we know it's easier said than done. This behavioral activation can be really, really effortful to begin with. It can be really hard to get started and to kind of break out of that bad cycle. So I like to think about it in like a few clear steps just to break it down. And I think really everyone can do this. Everyone can find a way to make this work for them. So The first thing that we do is identify a pleasant activity. So doesn't have to be something that feels like it's going to be, kind of a mountain to climb. I always recommend that folks start small. Just think about something that is pleasant for you to do these days. That's it. Keep the bar pretty low to start. This is a really important step. Then you schedule the activity. And this is so important because we know that PD really does a number on motivation, right? That's one of the primary issues in PD. Our motivation our motivation diminishes, and that's because of the loss of dopamine in the brain, right? So we know that it's really critical to kind of create this scaffolding that can support activity, because it's very common that folks feel in the moment like they don't want to do anything. They don't have that motivation. This is why we really encourage people to schedule the activity, because the idea is you're going to put it on the calendar and you're going to just do it, regardless of whether you feel like doing it in that moment when that time comes. Kind of like taking medications, I don't think that when we think about taking regular medications, we don't decide every time it's time to take a pill, oh, do I want to take this pill? Do I not want to take this pill? We usually just make the decision that I'm always going to take this pill at noon every day because I know it's going to make me feel better. I'm just going to do it. So we try to treat activities the same way. Okay, so third step is doing the activity. And again, even if you don't feel like it in the moment, it's time to do that. Here is a Tai Chi class, and you're just gonna go do it. And then the last step is just to notice, just start noticing your mood after you do the activity. Because we've found through a lot of research that even though PD can really reduce our motivation to get up and do the thing, almost always, once people have gotten up and done the thing, they do feel better. And that has huge benefits for getting into that virtuous cycle of doing more things that you enjoy, feeling better about yourself. Just to highlight some options for, ideas for these behavioral activation techniques. Like I said, we want to start small. We want to keep the bar low. Of course, exercise, any form of exercise, always great. Any kind of movement we want to support. But just these are a few ideas for pleasant activities that patients I've worked with have come up with in the past. And as you can see, a lot of them are really simple. Taking a bath, listening to a song you like, playing with your pet, talking to a friend, looking up at the night sky, watching a funny YouTube clip. I had a patient who loved to watch cat videos on YouTube. Great. Those are the kinds of activities to start with. And then this technique, it really builds on itself, and people find that they're able to do more and more. Okay. The second thing that I think about when I think about ways to improve mood in PD is cognitive behavioral therapy, or CBT. And this is a technique that is based on this idea that when we develop unhelpful ways of thinking, that kind of leads to a poor ability to cope with stressors, and then that limits our functioning in the world. And so the idea in CBT is that by changing the thought patterns, by changing the way we think, we can help the mind get out of some kind of cognitive ruts and pave sort of new, better roads of thinking. And that can really make people feel much stronger in terms of their coping, and that will help them kind of improve their functioning, do more of the activities that they like we just talked about, and that ultimately helps reduce isolation, build social connections, right? Usually CBT is offered as it's a pretty structured approach. It's a kind of therapy where you usually have a set number of sessions. It can vary. Sometimes it's as few as 5 sessions. It might be as many as more like 20, but it's usually it's quite structured. So it's not really like the kind of therapy where you kind of are lying down on a couch and just talking kind of in an unstructured way. It's kind of like a training program. And there's usually homework to kind of practice these skills. I mean, I think that it's actually quite easy to compare it to physical therapy. It's kind of physical therapy for your brain to help it get out of those ruts into healthier patterns of thinking. It takes practice, but there has been some really wonderful research in PD showing that this is really helpful for folks in terms of reducing depression and anxiety, improving function. And then the third thing that I want to highlight, the kind of third piece of addressing mood issues in PD is, of course, treating them with medication. This is a really important option to consider. There are quite a few different kinds of medications that we use to help with depression and anxiety in PD. They range in terms of kind of how they work. So there's often a good fit for, kind of a lot of different people. If there's something that you try and you don't like, there's probably another thing to try. There's kind of a whole array. And these medications are quite safe to take in PD. You can take them with levodopa and other medications that you might be using for motor symptoms. And they can really, really help to help people kind of like feel more resilient, less like they're on kind of an emotional roller coaster. I always say to patients that, they're not happy pills. It's not medications for mood do not kind of, it's not like you snap your fingers and you suddenly aren't going to feel depressed or anxious anymore. What I would say that they do is, or at least this is kind of what patients with PD usually say to me, they say, oh, taking these medications kind of gave me what feels like a thicker skin to deal with that kind of roller coaster, to deal with what's coming my way. And it let those things not have such a big impact on me. So that's kind of what I think they can be helpful for. And that, of course, combined with something like behavioral activation techniques and CBT, I think can do a lot in terms of increasing activity, increasing engagement, letting us connect with the people that we care about. Really important just to highlight quickly, if you're thinking about medications, finding the right medication for mood and the right dose can take time. And I always just like to highlight that because I think, it can be really frustrating that so much of treatment for PD in general, we still have to do through trial and error. That is hard. And unfortunately, the medications that we have for mood, they don't work quickly. They don't work on the order of hours or even days. Kind of, very different than how levodopa works. These medications for mood, they tend to work on the order of weeks to months. And so I always, talk with patients before we decide we might start, say, in a selective serotonin reuptake inhibitor for treating depression, and say, you're not going to feel better in a week and probably not in a month either. This is it's a slow process. We don't really know why these medications do work slowly, but we just see like there's a lot of evidence that folks really have to be patient, and then gradually that effect kind of builds. So in addition to just giving the medications enough time to work, and I always tell people that we're really talking about trying them for at least 2 months to see if they're beneficial. We also usually start at quite low doses and then gradually step up the dose. So For instance, if somebody tries a medication like the one I mentioned, like an SSRI for their mood, but they only take it for 2 weeks at a very low dose, we really have no kind of information about whether that is a medication that could help them. It's just not enough time, and it may not have been enough to see any difference. So I always encourage folks, if you can, if you want to, try to find a medication to help with mood, just know going in that it's going to take some time, and that if you can kind of stick with it and be patient with it and really wait to see the effect, you have a much better chance of finding the medication that is a good fit for you. Okay. We talked about 3 things. We talked about behavioral activation, we talked about cognitive behavioral therapy, and then we've talked about the medications. And we can talk in more detail about any of those during the Q&A. But I just want to say, sometimes when I talk to folks in clinic, it's interesting. Sometimes people often feel like they have to choose. They have to choose a treatment strategy if they want to work on their mood. They want to improve depression or anxiety. And I would encourage you to think of these options as a buffet and to try whatever is available to you. Some folks get a really good effect from one medication. Other people work on just behavioral activation for a while, and that's really helpful for them. Some people find that doing behavioral activation day to day, doing, 10 sessions of cognitive behavioral therapy, and combining that with 2 different medications, that's the best fit for them, that gives them kind of the best effect. I think that people really, everyone's body is, of course, different. Everyone's experience of PD is different. I think it's really important to just know that all these options are out there, and you don't have to choose between them. You can do all of them. You can try all of them. You may find that some are more helpful at certain times. Sometimes, for instance, when we have patients in our clinic that are facing a particularly difficult patch with PD, we recommend maybe doing that course of cognitive behavioral therapy, maybe doing that 10 sessions to try to build that coping, build that strength and resilience to be able to manage the challenges that are coming with the illness. Okay. And then the last thing I'll say before we, get into questions is, the last piece of this is if we want to really work on reducing isolation, strengthening our social connections in PD, we have to advocate for yourself as the person with PD, or also if you're here because you have a loved one with PD. I think we're still in a place with PD care where, like I said at the beginning, those problems that are at the very bottom of the iceberg underwater, they don't always get as much attention. They can be more hidden. There's less awareness of the mood issues in PD and how those contribute to people getting isolated. It's really important, I think, for all of us here to try to be advocates for making sure that we're paying attention to that problem and that we are trying to tackle it with proactive solutions. I think we know that, when we have visits for PD care, I think everyone is familiar with this. Everyone knows that they're going to do a motor exam, right? This is a key part of your visit with a provider for PD. We never miss that. But I really want us all to keep front of mind that that is not the only thing that we need to be attending to in PD, right? We have to be thinking about the whole experience of the disease. This is especially true for veterans. We know that if people came in already dealing with PTSD or TBI, they may have a bigger burden of those mood symptoms. They may be facing an additional challenge in terms of building that resilience, staying connected to other people, and avoiding isolation. So I really encourage folks, bring this up in your visits. It's a critical part of being able to live well with PD. And providers, I can tell you, we learn so much from people who are actually living with disease, people who have that lived experience. So help educate us, try to engage your providers as much as you can in brainstorming with you. Hey, this is becoming an issue for me. I see the way it's taking a toll on my health. Let's brainstorm strategies for how to tackle it. What can we do? And I hope that, what we've talked about today has given a couple of ideas, but I'm going to stop here and open up so we can have more of a discussion, and hopefully I can answer some folks' questions.
Thank you so much, Dr. Bradley, for your
Sure.
insights and the way that you encourage us to understand that this is a part of our life in navigating Parkinson's, but also in our history of being a veteran in service to the United States. So thank you for making those connections for us and on offering us an opportunity to explore resources and also educating us of what this means for someone living with Parkinson's as a veteran. We have a few questions that came in. The first question, Dr. Bradley, our attendee asks, how does acute PTSD, particularly experiences of anger and stress, how does this impact the symptoms and progression of Parkinson's?
Yeah, that's a great question. So in particular, sorry, you said acute symptoms, including the kind of, could you just say that part again,
Yeah,
the first part?
acute PTSD,
The
experiences of anger and stress. How does
anger
this
and stress.
impact?
Yeah, okay. Yeah, I think that certainly in I can't cite the, too much research on this particular issue, but I can say from like clinical experience that I definitely feel like, I think of anger and stress, those kind of acute symptoms as part of that, like that emotional roller coaster that can come with, it can come with depression, with anxiety, with PTSD. There's a lot of overlap between these disorders. I think that roller coaster absolutely exacerbates symptoms. I think lots of patients will report to me that when they find themselves feeling angry, feeling more stressed, maybe feeling anxious, they feel like all of a sudden they have more tremor. They feel like they might have more freezing, that they really are making that connection. So I absolutely think that is true. How those symptoms of anger and stress, how they affect disease progression, I think we know less about. I mean, like I mentioned, there's this hypothesis that maybe one of the things that happens is that, kind of upregulation of that stress response, like all the time. Obviously, we want a stress response. Like that's something our body is designed to do. It's really important. And managing stress is not inherently unhealthy, responding to stress. But when it's an upregulated stress response like all the time, which can happen in PTSD, what we think is that maybe that starts to take a toll on the body over time. It's possible that that does relate to disease progression in PD. It's possible, like I talked about, we know there's that dysfunctional HPA axis, the hypothalamic pituitary adrenal axis in PD. We know that there's elevated inflammation in PD. It may be that stress over time contributes to those problems. Could be that it kind of serves to accelerate them. But that's something that's still kind of being figured out.
So what can or how can our veterans impacted with Parkinson's disease develop stress-reducing habits?
I think that, there are a few different ways. I think that, like I said, I would encourage people to consider like kind of the whole buffet. I think the first thing to do is to, kind of understand where you're at. Like I find that, many veterans have maybe not been diagnosed with PTSD or anxiety or depression, but they have been dealing with those symptoms for a long time. So whether it's through, your VA, or if you're not in the VA or seeing other providers, either way, I would encourage folks to just start by bringing up those symptoms so your providers can start to get a handle on like, well, what's going on here? does it seem like PTSD is a big driver here? Because then that would help, guide you towards more of the treatments that we use for PTSD. That is like, I think, a really important first step. I think that there's some things that everyone can do on their own without seeing a provider, like the behavioral activation. People can also do things like mindfulness exercises, breathing exercises that a lot of folks find really helpful to reduce stress. But I would encourage folks to report those symptoms to their providers, because there is this buffet of treatment options. And it may be that actually doing something like cognitive behavioral therapy, there are particular types of cognitive behavioral therapy that are designed for PTSD that are a really good fit for folks with PTSD. And that could really help. Maybe that combined with a medication could really help to bring down that kind of chronic level of stress that's affecting the brain and the body.
You mentioned CBT, and one of our viewers, Linda Marie, and her husband are joining us today, and she writes in and shares, can a person with Parkinson's still benefit from CBT if they experience cognitive decline and slow processing?
That's such an important question. Thanks for bringing that up. Yeah, this is, it's really good that I think the short answer is yes. I think it's really good that there's a lot more attention to kind of adaptations of CBT for Parkinson's in recent years. There's, like I said, there's this great research that's being done, some of it in the VA, where, people are trying to engage folks with PD more and more in cognitive behavioral therapy and understand what are the best adaptations to make it a good fit for folks with PD. It is a cognitive therapy at the end of the day, though. So I wouldn't say that, for folks who maybe are at a point where they're dealing with dementia, I think that it may not be a good fit. I think there's a lot that we can do to, we can slow it down, accommodate slower processing. We can space it out a bit more, do shorter sessions. There's a lot of adaptations that can be done. So I'd really encourage folks to talk about it with their providers, to talk about whether it would be a good option. But I think, yes, it's absolutely still worth pursuing and considering. Because it is a somewhat cognitively demanding therapy, I'll say that it is something that's one of the reasons why, when we talk about putting money in the bank, it's one of these things that we do encourage folks to, even if they're not totally sure oh, do I need it right now? We always say, go ahead if you can and invest in it. Because I think that we can carry those, when we build those stronger coping skills, we carry them with us forward into the future. So I do encourage folks to try to access it early if they can.
Is there a way that we can filter or find a CBT certified therapist who understands the unique challenges of Parkinson's disease?
That's a great question. I would love if that were available. I don't know of a site off the top of my head that does that. But I will definitely, I will ask some of our CBT providers. I think that I would say, in the absence of a website you could go to, I think that trying to access a CBT therapist or a CBT group through a movement disorders clinic is probably going to be the easiest way to do that, because what you really want is providers who, although there isn't a separate certification at this point for CBT for folks with PD, but you're probably more likely to get connected with somebody if you go through a movement disorders clinic that they refer to again and again, someone who does have a lot of experience working with older folks. I also think it doesn't have to be PD. You can find CBT therapists maybe through a geriatrics clinic as well, folks that are just used to working with an older population that may have different kinds of neurodegeneration that they're dealing with.
Mhm.
So I would say go try to ask through those providers for referrals.
Connections, right? Through people that we trust. So if there's a provider that you
Totally.
trust who is a movement disorder specialist or works within the movement disorder clinic, it'd be a great place to start. Thank you for highlighting that, Dr.
Totally.
Greenway.
Yeah.
Another comment and share from Linda Marie. She shares that she's wanting to learn how she can encourage her husband to engage and stay motivated while also respecting his autonomy and managing his own care. And then she wants to be sure that we all know that we're both here listening. Thank you, Linda Marie, for being
Yeah.
here.
Thank you. Yeah, it's such a big question. It's really important and obviously comes up a lot in our clinics. This is really hard. It's really hard. And it's very personal, I think, where people feel those boundaries are.
Yeah.
One of the things that I often talk about with patients is the idea that, you know, increasing activity, helping folks get more motivated, or at least even if they don't feel motivated to still be able to do that behavioral activation, to do more things that are important to them. It can often be helpful to take the pressure off of the relationship. And what I mean by that is like the reason that we really harp on that idea of like it's so important to schedule activities, it's so important to create this structure, is because once you kind of like create a calendar, it kind of helps to make a little distance between like you and your loved one with PD, and that often that tension about like, can you get up and do this? I want you to do this. I want you to do this, right? Like just making it be kind of a schedule that you've made. You can kind of print it out or put it on the fridge, whatever is kind of a way that you'll both be reminded that it's there. It can help us give like some scaffolding rather than having to like have that debate in the moment, which can be quite challenging for a relationship. So always encourage folks, if possible, to like sit down during a time that where you're least stressed, during a time where you're kind of doing something enjoyable already, and make that map of structured activities. Again, starting really small, because I think we set ourselves up for failure if we start too big.
Mm.
So I always actually say like start with things that almost seem too silly to schedule. You know what I mean? Like it's kind of trivial. Like yesterday I had a patient who or Tuesday rather had a patient who scheduled going outside to sit and drink his coffee on the front porch in the sun for 10 minutes at 7 a.m. And he's going to do that, for 3 days this next week. Probably not the kind of thing that he would have put on his calendar a few years ago. But now with the motivational challenges with PD, with the fatigue he's dealing with the low mood, it does really help to schedule it. And it helped his partner. They put it on the fridge, they marked it down, and now his partner feels like they don't have to kind of like be kind of nagging, bothering, trying to push so much because it's already a schedule that they've agreed upon, and they set alarms to kind of remind him of when it's happening. So something to think about that may be helpful.
That is a very useful tool, and acknowledging that it does take effort and it takes work and it takes communication to get to this point of agreement between partners. So the question I'll offer is, are you willing to put in that effort to make
Yeah.
life feel easier and the conversations to feel more peaceful when the time comes to committing to whatever activity it might be that you or your husband needs to do or wants to do. Yeah, so it takes time and effort to get there.
Yeah, I love that. Thanks.
Many veterans are used to being self-sufficient. How can we shift our mindsets to seek and be willing to accept support?
Great question. Yeah. Yeah, like I said, I definitely have worked with a lot of veterans where I'm just floored by what they have been able to kind of withstand and deal with, right? And it's very common that they will tell me that no, they've never gotten help for any of this stuff, and that they feel like that's kind of good. That's kind of what they were supposed to do. I think that, really trying to keep front of mind that dealing with PD, living well with PD takes an incredibly proactive um, proactive mindset and kind of like set of skills. Like there's a lot to be done to live
Mhm.
well with PD, right? You said it's a big job. Um, and so I try to, like, when I'm working with veterans, frame it that way. As some people feel like it's difficult to quote like ask for help. Well, if that idea feels really hard, then think about, you know, trying to take as much control as possible of your health and wellness, if that's
Mm.
a better framing. Part of taking control and being proactive with your own health is making sure that you are supporting your mood, are supporting your social connection as much as possible. It is part of this job, if your goal is to live well with this disease. And so sometimes actually, like, the diagnosis of PD, I find can be the thing that kind of like pushes people over that hump, right? Of realizing that they've been like dealing with and kind of surviving with maybe these problems like PTSD symptoms for a long time, and like sure they can get by, but are they going to be able to like live well with PD now?
Mhm.
Maybe not, right? And so that kind of sometimes pushes people over into that like more proactive stance of like, I can have a much better quality of life with this disease if I get appropriate treatment for these, what are very real, whether they're illnesses from war or sometimes they're not directly from war, but still the consequences are the same when you have PTSD. Um, I think, recognizing these are very real problems with very real health consequences. We
Mhm.
know that, like, there's a ton of research showing that, and they really deserve the same attention that we give your tremor and your gait.
I've often heard in my years of working with and advocating for people with Parkinson's that it's not the motor symptoms that impact our well-being and our livelihood. It's the unseen, the unspoken symptoms. So
Absolutely.
putting in that plug
Absolutely.
of the importance of breaking the silence of what's happening in here and in here that goes beyond the flesh and bones that we see externally.
Yes. Yeah. It's so easy, right? It's so easy for all of us to focus on the stuff that feels like kind of more tangible. You
Mm.
can see a tremor, you can see issues with gait. It's harder to deal with the stuff where we can't quite see it, but it's so important. Just because you can't see it doesn't mean it is not harming your body, right?
Yeah.
And getting back to like kind of the way you all titled this webinar, I think that idea of like, of breaking the silence, like that is the veteran or the person a few minutes ago asked like how to shift that mindset. One of the ways to shift that mindset is like break that silence, like don't try to shift it alone.
Mm.
You know, consider showing up at a support group, drop in, like hearing from other people who are having the same experience or navigated it a few years ago is incredibly powerful in
Mhm.
terms of people realizing like, oh, I'm not alone in this. And oh, like lots of people are doing lots of things. What can I learn from this person? What can I learn from that person? Oh, that doesn't sound like that would work for me, but that sounds really good. It's just like, it can be a really motivating and helpful kind of data gathering mission. So I also
Mhm.
really encourage people to do that.
We have a question here of interest saying, I just wondering if you've noticed a difference in mental wellness from the generations of veterans that you may be treating in your practice, Dr. Bradley, if you've noticed a difference in the generations of veterans with their mental wellness.
Oh, interesting. Um, yeah, I like that question. So I think that I think I'd say that, often, like I mentioned a bit about this earlier, a lot of the folks I meet who are older, who maybe are veterans from Vietnam or even earlier, many of them, because there was kind of like less availability of support at that time, unfortunately, than there is now, have been dealing with kind of the consequences of something like PTSD for a very long time. And I would say one of the challenges there is that sometimes because of those like untreated symptoms, um, folks like the guy I mentioned who didn't go to baseball games, like folks have kind of narrowed their lives and their social orbits and like have become more isolated or kind of like staying in this kind of much smaller, safe feeling orbit. And and I think that that can be a real challenge, kind of like thinking about how do I like re-expand that orbit safely, you know, which may mean that symptoms that have been kind of dormant for a while because you've been avoiding having them, by this keeping the small orbit, symptoms might start to feel a little more present. And so that's why I really encourage those people. I'm like, even if it has been decades since your injury and you have never gotten help from a psychiatrist, a psychotherapist, a counselor before, now is still the time. Now is absolutely the time because that will give you kind of a safe environment where you can work on fighting that isolation, work on re-expanding. I think that's something that we often see, especially in the older generations of veterans. And I think and I hope it's changing for the younger generation as there's kind of more awareness of injuries like PTSD and TBI and their consequences, and hopefully better treatment like right after people have these initial injuries.
Mm. We're getting more questions about CBT, Dr. Bradley, and thank you, Gregory, for sharing in the Q&A. They're sharing that he himself is a veteran and his wife has Parkinson's disease. And the question that he offered is, would CBT help us together? And then they followed up with, my wife just left. She doesn't think that CBT would be helpful. I'm curious, Dr. Bradley, if you could speak to perhaps the resistance or hesitation of doing what we call thought work and how you need to be prepared to come into that mindset of willing to shift the way that we think about things.
Yeah, absolutely. It is, look, it's hard to initiate any treatment. It's hard to, especially one that is kind of going to take practice, homework, it's not, there isn't a CBT pill that we can take. So I totally understand that. And we also know that the toll that PD takes on motivation makes everything feel harder from the get-go, right? Often people can do a lot more than they think, but we usually, in kind of a non-PD state, we rely a lot on our sense of motivation, that sense of like a reward of what's going to come in the future. So it's harder with PD, right, to generate that motivation. So it's really, it's so understandable when people are like, that is overwhelming. That's too much. What I would say is that, and something I really like about CBT, same is true with behavioral activation, is CBT doesn't start by, you don't come to, whether it's group or individual, you don't come into the room and the therapist doesn't say, now it's time to shift your mindset. That is not what happens, That's not what happens. It is a gradual, stepwise process where you really learn techniques, you learn strategies, just like when you go to PT and you learn some exercises, but the real work is then like each day you like do a little bit of practicing that, just a little bit. You're not like living your life totally differently. You're not like changing your whole schedule. You're just trying to bring in these new skills where you are starting to become a little more aware of certain thoughts and those cognitive ruts, and practicing kind of stepping out of them, just practicing little by little. Over time, I think people find that they experience quite a shift in how they see themselves and how they see like how they're doing, right? Like that guy going back to church, that patient that I worked with, right? Like over time, he did just feel differently about kind of whether he should go, and what if he got some really bad, what if he was shaking really bad in church, like what would happen? And he ended up deciding that that was okay if that happened, you know, that was okay. He could cope with that in a few different ways. And he kind of came up with those strategies that allowed him to then do the thing he wanted to do. So I would always tell people, don't start by thinking like, oh my God, I have to shift my mindset. All you have to do is show up and start this like kind of little kernel of noticing and shifting, and the CBT therapists are going to help you figure out how to do that. You don't have to like learn yourself. There's like ways that they help you kind of practice that in small ways, but it's really gradual and stepwise.
You're reminding me of a phrase that my therapist offered me when I was going through CBT. And she said to me, little by slowly, again and again.
I love that.
Little by slowly, again and again.
But if we had a t-shirt for CBT, that's what we should put on it. That's great. Yeah, exactly.
I'm keeping an eye on our time, Dr. Bradley. We have about 8 minutes left to share with our community and a couple of questions here. So there are a couple of questions about medications. Are you in a place to respond to questions about medication?
Sure. Yeah.
Okay.
Absolutely.
So
I'll try my
several of our
best.
community members are asking, if you could share some medications that work well with Cinemet that treat symptoms of depression and anxiety. And they wrote in here, I've heard that some can worsen dyskinesia. Could you address those?
Yeah, absolutely. So there, I'm not sure about the dyskinesia. I wonder if you can tell me which medication you might be thinking of, it might jog my memory. What usually stands in people's way is sometimes there are certain medications that primarily work on serotonin that actually not just in PD, but they can cause tremor. And so that's something that sometimes people are like, oh no, like, I can't have that. I think the thing that is important to know is, first of all, that only happens in a minority of people. That does not happen in most people. It's not happen in most people with PD when they start these medications. The second thing is, it's not a worsening of Parkinson's. If you do get some tremor related to those medications, it resolves when you stop the tremor. So I don't want people to be worried that, oh, this is like somehow worsening my illness. But like I said, we don't see it that much. The medications that we use to treat mood in PD are ones that are mostly come from the way we treat depression and anxiety in non-PD patients, just in the general population. So there are medications a lot of folks are very familiar with, like the selective serotonin reuptake inhibitors. Examples of those are medications like escitalopram or Lexapro, sertraline, the brand name is Zoloft, fluoxetine, the brand name is Prozac. All of those are kind of in that class. There are other medications that are not only serotonin, but also norepinephrine reuptake inhibitors. So they work a little bit differently, more involved with this other neurotransmitter, norepinephrine, which is also important for mood. Those are duloxetine, the brand name is Cymbalta, or venlafaxine, the brand name is Effexor for that one. And then there are still, like, you know, another class of medications that we give, we just have people take at night. Mirtazapine or Remeron is one that we often prescribe for folks to take at night. That's a medication that the reason people take at night is because it is a bit sedating. And so it can help with both mood and sleep. It also can like boost appetite a little bit. So it's often a very good fit for folks with PD because it kind of gives you that, like, you know, dealing with like 3 potential problems at the same time. And yeah, there are other ones, you know, if people have specific questions about one, there's a newer medication that came out a few years ago that's now, I think, more widely available, called vortioxetine or Trintellix, that, you know, is helpful for mood, but also seems to have some benefits for cognition. So the way that we usually approach this, as you can see, even just within, you know, medications, there's a buffet. There's definitely this buffet. The way that we usually choose a medication to start with is we kind of look at those the combined effects, like the serotonin norepinephrine reuptake inhibitors, the SNRIs, like duloxetine and venlafaxine. Those we use a lot in our pain clinics, actually, to treat pain. They don't just treat mood, they also seem to treat chronic pain, especially when it's nerve-related pain, which a lot of folks with PD are dealing with. So if I see a patient who is dealing with some depression, is dealing with some anxiety, and also has chronic pain, I might suggest, oh, let's try one of these SNRIs because it might kind of help with multiple problems at once. So that's really how we do it. It's very individualized, usually the way we select medications. And then, you know, like I said, we want to give each one like a couple months, but if one doesn't work well, is not a good enough fit, we try another one, maybe one that has a slightly different mechanism. And they're also okay to use together. There's a lot of times when we will use, say, like that, maybe that medication that I just mentioned, like one of the SNRIs, but maybe somebody's also still struggling with sleep. So we might add a little bit of that mirtazapine or Remeron at bedtime to try to help them get a little bit more sleep. And it might help with mood a little more at the same time. You know, sometimes you get these kind of, just like when you're treating motor symptoms, you can get these kind of synergistic effects between medications that give certain people a better result.
Thank you, Dr. Bradley. It's
Of course.
what's obvious in your response to that question is there are so many resources, whether it's medication or cognitive therapy or outdoor therapy or singing your favorite song or sitting down and creating a schedule. There are ways to manage our mental wellness, and there is an effort that's required on behalf of ourselves to get us there. We went pretty deep into the medications in that last response, so I'll just encourage folks to browse the Parkinson's Foundation's website. We have whole entire webinars dedicated to understanding different types of medications, whether that's treating symptoms of depression and anxiety, low mood, apathy, dyskinesia, gold standard options for people with Parkinson's. So I'll ask my team to drop a link in the chat to our recorded webinars for you to browse more in depth
Great.
about medication options.
Awesome.
Dr. Bradley, as we wrap up our time today, I'm curious if you have sort of like a pearl of what's the most important piece of advice that you could give to a veteran who's struggling with emotional and social challenges of living with Parkinson's disease.
I think the most important thing that I want to get across as a doctor who has worked with veterans quite a bit is, you know, you really deserve treatment for these symptoms. These are, you know, feeling isolated and lonely. It's not just something that people can necessarily just shake off or tackle on their own. Like we focused on here, underlying problems like depression, anxiety, PTSD are often driving that isolation and loneliness.
Mhm.
And I really want veterans to feel and know that they have earned and deserve treatment for those problems. And we have a lot of treatments. So please bring them up to your providers, whether it's in the VA or outside the VA, and let's try to get you connected with these treatment resources that are the best fit for you. We'll show you the whole buffet.
Yeah. Thank you for highlighting the importance of what's available to our community of veterans living with Parkinson's disease, Dr. Bradley. And thank you so
So
much for
much.
sharing your time today. You've
Thank
been
you.
such a pleasure to hear from and to work with. And I hope that our community will continue to be curious about their mental wellness thanks to your inspiration.
Thank you so much for having me. Thanks everyone who joined. And yeah, I really appreciate everyone's time today and the fantastic questions that I think will probably be helpful to lots of people watching. Thanks.
And today's webinar and the entire Veterans Webinar series is presented with support from the Don and Lorraine Freeburg Foundation. I want to take this moment to thank the Freeburg Foundation for helping to make these programs possible. The Parkinson's Foundation wants to hear from you. Through our PD Story page, the Foundation shares stories written by anyone in the Parkinson's disease community. These stories help bring awareness to this life-changing disease and helps to inspire others. As a veteran or the loved one of a veteran, your experience with PD is unique. We encourage you to submit your PD story and share your experience with others in the community. To learn more and to submit your PD story, you can visit parkinson.org/mystory. Don't forget to visit our webpage and explore the resources offered by the Parkinson's Foundation that can support your navigation of living with Parkinson's as a veteran. That website again is parkinson.org/veterans. And there were a few questions that we weren't able to answer today. Things like how to get connected with a therapist who knows Parkinson's disease, looking for a movement disorder specialist that you know and that you trust. If you have a question that did not go answered today, do not hesitate to reach out to our helpline by calling 1-800-4PD-INFO. You can also email them at helpline@parkinson.org. Our helpline is staffed by Parkinson specialists and can get you connected to resources in your area or virtually online in the safety of your home. Yep, all the things are listed here on the website. And again, we thank you for joining us today and hope to see you again soon. Be well.